Hi friends, when we first start a rotation in the neonatal ICU, there's one condition we are almost guaranteed to see, but it often feels confusing, and that condition is PPHN, or persistent pulmonary hypertension of the newborn. You may see a baby with desaturation and respiratory distress, and then you assume that the baby must have some lung problem. But then your senior may suddenly say that, oh, this is a case of PPHN, and then she orders so much investigation like inotropes, inhaled nitric oxide, and then step up the ventilation, do the echo. And it's usually a bit confusing in the beginning. So therefore, I make this video to explain this condition. This video may be a little bit longer, but I can reassure you that once you understand pathophysiology, especially the vicious cycle of PPHN, every investigation and management will suddenly make so much sense. And by the way, if you're new here, I'm Dr. Oliver. I'm a pediatrician with over 10 years of experience working in general peds, the PICU, and also the NICU. I created this channel, Paediatric Squad. I hope to build up a community for pediatric healthcare providers like you, and to help all of you ease that steep learning curve. So let's get to work. Chapter 1. Pathophysiology. Before we get into the pathophysiology of PPHN, we must first understand the normal physiology of fetal circulation. Don't worry, I promise to keep this simple and relevant. So first, let's picture the fetus. They are floating in the uterus and surrounded by the amniotic fluid. Therefore, their lungs are fluid-filled, and the baby is not breathing. And because of this, actually the PO2 in their lungs are very low, which make the pulmonary vessels constrict. And also, the fluid in the alveolar is physically compressing the pulmonary vessels. Both of these would make the pulmonary vascular resistance very high. And also, since the lungs are essentially not functioning, and the baby must get oxygen from the placenta. So here is the journey of the oxygenated blood. It travels from the umbilical vein through the ductus venosus. So ductus venosus is exactly where you pass your umbilical vein catheter, UVC. Alright, so after it goes through the ductus venosus, it goes into the IVC. And then when the blood goes through the IVC, it hits the right atrium. And there is a structure called eustachian valve, which actually acts like a traffic director. So it mechanically directs this high velocity stream straight at the foramen ovale. So foramen ovale is a hole between the left atrium and also the right atrium. So now remember the pressure rules. The blood will flow from high pressure place to a lower pressure place. And because the pulmonary resistance is so high, the pressure in the right heart is higher than the left heart. Therefore, the blood naturally flows from the right atrium through the patent foramen ovale, or the PFO, into the left atrium. Eventually goes to the left ventricle and then out to the aorta. And right after it goes out from the aorta, is applied to coronary arteries and also the brain. And at the same time, we have the deoxygenated blood. So they come from the brain and then goes to the SVC, superior vena cava. And this stream actually enters the right atrium, but is direct downward through the tricuspid valve, and then goes into the right ventricle and out to the pulmonary artery. But again, because the pulmonary vascular resistance is so high, and therefore it would go through the ductus arteriosus from the pulmonary artery into the descending aorta. And remember, in preterm baby, one problem is patent ductus arteriosus, PDA, and this is where it happened. But when the baby is born, two massive changes happen instantly. So first, the baby cries. These will expand the lungs, and the lung is full of oxygen now. And since oxygen is a very potent vasodilator, remember this concept, oxygen is a potent vasodilator. So the pulmonary vessels will physically open up because so much oxygen in the lung. And therefore, the pulmonary vascular resistance will drop dramatically. Second, when we clamp the cord and remove the placenta, the systemic vascular resistance will increase. And therefore, we now have a situation where systemic vascular resistance is higher than pulmonary vascular resistance, and the right to left shunt will stop. And also after birth, the PFO and the ductus arteriosus begin to close. And this is a normal transition. However, in PPHN, this transition failed. Remember, PPHN stands for persistent pulmonary hypertension of the newborn. And the name actually tells you exactly what the problem is. The baby's pulmonary vascular resistance remains persistently high after birth. But don't worry about the causes of PPHN yet, I will explain those later in the video. Now let's focus on what will happen if the pulmonary vascular resistance remains very high. This leads us to the most important concept of the whole video, the vicious cycle of PPHN. Because the pulmonary vascular resistance stay higher than the systemic vascular resistance, and the blood continued to go from the high pressure place to the low pressure place, and therefore we will continue to see a right to left shunt. And this shunt happen in two specific places, as I said, the ductus arteriosus and the PFO. So after birth, the right side of the heart and or the pulmonary circulation are actually some deoxygenated blood. If the right to left shunt continues, the deoxygenated blood will enter the systemic circulation. So you can imagine that there are some mixing, and this leads to systemic hypoxia, and also the end organs like the kidney, the brain, every cells of your body are actually having poor perfusion. So this is where the vicious cycle begins. Poor perfusion to the end organ will lead to anaerobic respiration. And if you remember your high school biology, anaerobic respiration would produce lactate, which would lead to acidosis. So here is a critical link. Acidosis and hypoxemia are both patent vasoconstrictors of the pulmonary vessels. Therefore, these two can cause the pulmonary vascular resistance to rise even further and worsening the PPHN. So now we have a vicious cycle, but it doesn't stop here. The high pulmonary pressure actually forces the right heart to work so much harder, which can lead to the right ventricular hypertrophy. And eventually, this can cause impaired right ventricular function and also dilatation, lead to right ventricular failure. And therefore, when your right ventricle is weaker, there is less pulmonary blood flow, which can worsen the hypoxemia. And furthermore, actually the right ventricle work together with the left ventricle. They work as a unit. The right ventricular dysfunction can lead to left ventricular dysfunction as well because of interventricular dependence. So when the left ventricle also starts to fail, the end organ perfusion drops further, and it leads to worse acidosis, and again this will lead to worse PPHN. And therefore our job in the NICU is to break this cycle. But to treat this effectively, you first need to know why the resistance is so high in the first place. Chapter 2, Causes of PPHN. When we look at the causes of PPHN, we generally classify them into two main categories, primary and secondary. So primary, also known as idiopathic. Primary PPHN is actually quite rare, accounting for only about 10 to 20% of cases. And this is defined by the absence of any parenchymal lung disease, which can explain those elevated pulmonary pressure. So essentially, it means that the lungs looks normal, but the vessels are abnormal. The vast majority of causes you see are actually secondary PPHN. It could be due to lung, the brain, and the heart. First, let's talk about the lung, which is the majority of the secondary cause. Conditions like meconium aspiration syndrome, MAS, congenital pneumonia, RDS are classic causes. In these causes, you will have VQ mismatch, and therefore when the lung is bad, you get hypoxia and acidosis, which, as we just learned, which will cause vasoconstriction and trigger PPHN. And there are also other mechanisms play here, like the inflammatory mediators or abnormal muscularization of the vessels in this condition. Next cause is the brain, specifically hypoxic ischemic encephalopathy, HIE. So babies with HIE often have a delayed transition at birth, so their pulmonary vascular resistance remains persistently high. And also some of these babies are on therapeutic hypothermia, which we use to treat HIE. This therapy can sometimes worsen the pulmonary constriction and lead to PPHN as well. And finally, is the heart. Some congenital heart disease can also lead to PPHN based on their pathophysiology. So therefore, when you saw a case with PPHN, you can running through this mental checklist to find out the cause: lung, brain, and heart. Now, we know about the why. Let's talk about how. How do we actually recognize and diagnose the PPHN? Chapter 3, Presentation and diagnosis. So the spectrum of PPHN presentation is wide. You may see a baby with just mild hypoxemia and minimal respiratory distress, or you may face a baby with a severe desaturation and respiratory failure. Therefore, your clinical examination is very important. And the easiest clue we look for is the pre and post ductal difference, which means we measure the SpO2 of the right hand, which is also known as pre-ductal, and the lower limb, post-ductal. There are a difference between them. So here's the logic. The ductus arteriosus connects to the aorta distal to the left subclavian artery. So the blood flowing past the ductus arteriosus actually supplies the lower body. And therefore, the SpO2 over the lower limbs are regarded as post-ductal. So you can imagine, if there is right to left shunt across the ductus, the deoxygenated blood will mix in after the subclavian artery. And therefore, the post-ductal SpO2 or the lower limb SpO2 would be lower. And when you look at the anatomy, the right hand is actually supplied by the brachiocephalic artery than the right subclavian artery. So even if there is right to left shunt, the SpO2 over the right hand will still be high because there is no mixing yet. So if there is difference of SpO2 between the preductal, the right upper limb, and the postductal, the lower limb, we can say that the baby is likely to have some right to left shunt. And generally, a difference of greater than 5 to 10% is considered significant. Also, one more tip here. In PPHN, the hypoxemia is usually labile, meaning that the saturation can swing up and down, especially when the baby is irritable. They may have desaturation. So, if you see fixed hypoxemia, there is no difference when the baby is struggling, you may suspect a cyanotic congenital heart instead. After we spot the pre and postductal difference in the SpO2, we suspect the baby is having PPHN. Next, we'll look at the chest X-ray. So actually we're looking for two things. First, lung pathology. For example, any features of congenital pneumonia, MAS, and also look at the heart shape, which may be suggestive of congenital heart disease. So if you see a clear lung field but the baby is blue, you should think of either idiopathic PPHN or again cyanotic heart disease or hypoxic ischemic encephalopathy. But ultimately, echo is the gold standard to confirm PPHN. So when we do an echo, we're actually looking for few specific signs. First, we look for tricuspid regurgitation. When the pulmonary pressure is high, the blood falls back from the right ventricle into the right atrium. So the pressure gradient we measure in the tricuspid regurgitation jack actually directly reflects the pulmonary pressure. Second, we look at the shunt direction across the ductus arteriosus. A right to left shunt confirms that pulmonary pressure is exceeding systemic pressure. Finally, echo also allows us to assess both right ventricle and left ventricular function. As we said, ultimately, PPHN can affect both the right ventricular function and also the left ventricular function. So echo is very useful. And once we have confirmed the diagnosis, we need to treat it. But before we dive into management, I want to give you something to help you on your actual shifts. I know exactly how hard it is to remember the drug doses and developmental milestone, so I created a pediatric beginner kit, the essential formulas in pediatrics, and also a developmental milestone cheat sheet. And they're completely free. Just click the link in the description below and I'll send them straight into your inbox. Print them out, put them in your pocket, and save your brain power for the patient. And now, let's get back to how we treat PPHN. Chapter 4. Management. The goal in management of PPHN is simple. Break the vicious cycle. We can achieve this by attacking different parts of the cycle from multiple angles. First, we start with general measures. Please do not underestimate these general measures. Usually these can help. As I said, these babies are very labile. Even minor stimulation can cause a massive desaturation, and therefore we should practice minimal handling. Do not suction routinely, and also more importantly, we need to give adequate sedation if the baby is irritable. And other general things include we need to maintain a normal temperature, normal electrolyte, and normal glucose. Do monitor for that, and pay special attention to calcium and magnesium because hypocalcemia can worsen the PPHN and hypomagnesemia can lead to further fetal constriction. Then we can look back to the vicious cycle and we can tackle each step one by one. First, we treat the underlying cause, which is usually the lung. If the baby is intubated, the ventilation strategy is important. Both underinflation or overinflation increase the pulmonary vascular resistance. So we aim for optimal recruitment of the lung. Usually it means 8 to 9 posterior ribs on the chest X-ray. And we use gentle ventilation with optimal PEEP. This means relatively low peak pressure to avoid damage, and we often allow a degree of permissive hypercapnia to balance the lung expansion while limiting the barotrauma. And in severe cases, we may step up to a high-frequency oscillatory ventilation. And if the PPHN is secondary to lung disease like MAS or RDS, early surfactant can also help. Some RCTs have shown that surfactant plus inhaled nitric oxide actually works better than the nitric oxide alone in reducing both the death and also the ECMO risk. And speaking of oxygen, we need to maintain O2 saturation. We aim for pre-ductal saturation in mid-90s, and we must avoid hypoxia because it can cause pulmonary vasoconstriction. But at the same time, we need to avoid excessive oxygen because animal studies suggest that overshooting oxygen can paradoxically increase the pulmonary pressure. Second, we decrease the pulmonary vascular resistance directly. And our first line is inhaled nitric oxide, NO. So we typically start at 20 ppm, and higher doses are not recommended because they can increase the risk of methemoglobinemia. So make sure you monitor the methemoglobin levels when you start the INO. So if the INO is not working or is not available in your hospital, we have other options. Sildenafil, so which is a PDE5 inhibitor that actually can dilate the pulmonary vessels. But watch out for any systemic hypotension if you use that. Another drug is an inotrope, Milestone. So this is an inotrope and also a vasodilator. It can dilate the pulmonary vessels, and at the same time it can help the right ventricular function. And this is great that if the ventricular function is not good. But again, watch out for hypotension when you use this drug. Third, we can increase the systemic blood pressure. And remember, the pathophysiology of PPHN is mainly due to right to left shunt. So therefore, if we have systemic pressure higher than the pulmonary pressure, we can reverse the shunt to left to right. So if the baby is hypovolemic, we can give fluid bolus to boost up the systemic blood pressure. But if it's euvolemic, you should not further give fluid bolus. And also more often, we use inotropes. And we choose them based on the physiology. For example, if the left ventricular function is not good, we can choose adrenaline. If the baby is having sepsis, we can choose noradrenaline or milrinone for right ventricular dysfunction. So therefore, echo is quite important to help you guide the decision. And finally, if the PPHN cannot be well controlled after all this measure, the baby is deteriorating despite all of this, our last resort is ECMO, which can let you take over the work of the heart and the lungs, and it acts as a bridging therapy to let the lungs to recover. Thanks for watching until now. I hope this video can help you understand more about PPHN, and once you remember the pathophysiology of that, actually everything will make sense. And before you go, I want to say something important. Starting in the NICU is incredibly tough, and I know it feels overwhelming and very stressful in the beginning. Please give yourself some time, and you are not expected to know everything on day one. I know that it is a steep learning curve because I have gone through that as well, but I promise you, it does get easier with time. Keep learning, remember to stay kind to yourself, and I will see you in the next video.